And so Josh Nickerson, who's one of my colleagues, went to Kenya about, I think, 4 or 5 years ago now. And while he was there, he had a great experience. And that was through one of the American Society of Neuroradiology's international initiatives. So he was a visiting professor there. And Gregory Obala was somebody that he met and was very impressed with. And then when Josh came back from Kenya, he came to me. I'm the fellowship director for the neuroradiology program at OHSU, and he said, I want to recruit Dr. Obala because I was very impressed with his abilities. And so Greg came here and then did a great job. He's finished with his 2 years of neuroradiology, and now he is doing nuclear medicine currently. But I came to Greg after I joined the international committee of ASNR and said, is there anyone that you could introduce me to in Kenya for an activity related to the committee I'm on, which is the international committee? And Greg said, sure. So just my international experience and why I wanted to be on the committee is because I worked for 4 years in Japan as a radiologist, and then I also worked with Dr. Polaseni at the University of Iowa when I was a resident, and that's how I got to be involved in the international committee. And here we are. So Dr. Heyman, as somebody who volunteered to give lectures and was interested in getting involved in the international activities of the American Society of Neuroradiology. And so in a nutshell, that's how we got to be here today. So I appreciate everybody who worked together to get this quite large group together. And with that, I will turn the floor over to Dr. Heyman for maybe you can tell us a little bit more about yourself and then give us your lecture.
Sure. Thank you so much. Yeah, my name's John Hyman. I'm a neuroradiologist at the University of Texas Medical Branch in Galveston, and I am interested in lecturing. I saw this opportunity. I'm a member of the ASNR, come up to give international lectures. So I thought, that's something that I would be interested in. My program is fairly culturally diverse. We have a number of international medical graduates, as well as American medical graduates and DOs and things like that. So I like I appreciate cultural diversity. I enjoy learning about other cultures, and I like the opportunity to talk to and lecture to a broad range of people. So I don't have much to say about myself. I'm the program director. I have been for a couple of years, and I did a neuroradiology fellowship at Northwest Memorial Hospital in Chicago. But let me pull this lecture up here. It always takes me a second, even though you would think this far into the pandemic, I'd have it down to figure exactly.
Excuse me, Dr. Heyman. I don't know if it's just me, but you're quite faint.
Okay, I might do this. This is I'm at my workstation. Does speaking directly into this dictaphone help?
Still don't hear you very clearly. I don't know if it's just me. Maybe someone else could just say if they can hear you.
It's the same thing for me. It's quite faint.
Yes.
Even with the dictaphone close to your mouth.
Well, that's unusual.
Okay, others are saying it's clear on their side, so I guess we can just proceed.
This is Joseph Abuya. It's quite clear on me. I think I'm hearing John Hyman very clearly as a neuroradiologist, and I, even with the dictaphone closer, I'm even hearing you and much more better. Thank you.
Okay. Well, I'll try and speak up for everybody. I'm not sure what else I can do about it.
I think we'll try and work on our settings, like our
Okay.
volume settings on our end. Thank you.
Okay. Okay, so I'm sharing, I should be sharing, and then let me see, let me switch this, display settings, swap presenter and slideshow view. So are you guys seeing my whole screen now, the big screen?
Yes, we are.
Okay, perfect.
Yes, we are, but please use your VRS, I mean, your microphone closer. It was helping actually when it was closer to your mouth.
Okay, yeah, I have it. I think I was also raising my voice a little bit. I'll try to maintain that decibel level. So this is on face, it's a simple lecture, cerebral surface anatomy, but I find it to be, this is the one lecture that I give my residents every year, which means that they see the lecture 4 times over the course of their residency. And I think that each time they see it, as they go through, they pick up more and more because there is a lot of information in it. And I find it to be an incredibly practical lecture, which is good because I think people take away useful things from this lecture that they can actually use in their day-to-day practice. And I enjoy actually giving it because it reminds me of some of the really nuanced anatomy. So I like this lecture because it's useful and it's good for trainees of all stages, from beginning radiologists really to the faculty level. Just a brief shout out. I made this lecture actually when I was a fellow, and it draws on information from a textbook chapter by Thomas Nadick, who is he's a neuroradiologist and was actually the uncle of my program director, Michelle Nadick, or my fellowship director in Chicago. And it also it uses images from headneckbrainspine.com, which is, I think, a now defunct website that was made by a neurofellow from Duke. So that's where the imaging comes from. And then I did like overlays on it and stuff like that myself. So let's get started. The rationale for this is kind of based on, and somebody asks you, where is this infarct? You don't find yourself doing this and being like, it's kind of here in this area. Anatomy, as we all know, is really the cornerstone of radiology. And it's really important to, especially as radiologists, to know anatomy very well, especially in neuro. Form and function, I think, is really more closely tied in neuroimaging than really in anything else. So when clinicians give you clinical data about, where a stroke might be or about where a deficit is, if you understand anatomy, then it can really help you to make very subtle diagnoses. Like, okay, this patient has internuclear ophthalmoplegia. Oh, okay, I know I'm going to be looking for like a punctate infarct in the MLF, the medial longitudinal fasciculus. That's just an example, but the idea is that in knowing these things, you can make a lot more nuanced diagnoses. Secondly, I think that knowing anatomy well increases our legitimacy as clinicians. In other words, when you have referring providers, and I always think about head and neck imaging in this regard, because I read a lot of outside hospital studies that are read by generalists and uploaded for reinterpretation. And, they'll say things like, oh, there's a lesion in the oropharynx, and it's not, it's hypopharyngeal or laryngeal, or vice versa. I always think like, what does the referring provider think? Like, how can they take anything else in that report seriously when they don't have a grasp of the basic anatomy. And then finally, and this is something that I tell my residents, if you know the anatomy well, it'll facilitate your dictations. It just makes it so much easier to describe things when you have the anatomical repertoire at your fingertips to at least talk about like where things are. So I think that these are sort of broad reasons to learn anatomy. There are other reasons, like an example I give is, and this is what the point of this lecture is talking about. We're going to talk about how to understand specifically cerebral surface anatomy and conserved landmarks that are going to allow you to navigate your way around a brain and find out where you are despite certain anatomical variations, despite anatomy being altered by pathology or iatrogenically by surgery. And this is an important one, I think. If you want to be a high-level neuroradiologist, you have to understand things like, there are inconsistencies in the orientation of a study between CT and MR, for example, because of alterations in the positioning of the patient's head when axial images are obtained, or even between CTs or between MRs in the same patient. And that becomes important when you're following metastases, when you're measuring tumors and things like that. So you really kind of need to understand anatomy based on landmarks and not just putting images side by side and comparing them. I've seen it multiple times where somebody will say, oh, this metastasis resolved completely, but now there's a new metastasis here. And I'll say, no, that's the same metastasis. And they'll say, no, look where it is in the AP dimension. I say, I understand that. The slice it's going through a different area of the brain, but look, it's in the precentral gyrus in both cases. If you look at landmarks, it's in the same place. So this is kind of the rationale for this lecture. I think I hope you all get something out of it. So let's jump right in. So we're going to start with very basic lobar anatomy. Okay. I think everybody knows generally there's 4 lobes in the brain. There's a frontal lobe, parietal lobe, temporal lobe, occipital lobe. And then, some people consider the perirolandic cortex its own lobe. But generally, we have these 4 lobes, and 2 of them, the frontal parietal and the parietal occipital, are separated by defined landmarks. In other words, the central sulcus separates the frontal lobe from the parietal lobe. The parietal occipital sulcus separates the parietal lobe from the occipital lobe. And then the Sylvian fissure, I guess, separates the parietal lobe from the temporal lobe. But these 2 here, and I think, this is an area where people get into trouble dictating just what do we say. There is no sort of hard anatomical line that separates the parietal and the temporal lobe. They just sort of blend, right? And the same thing from the temporal occipital. So people handle that in different ways. They say, oh, this is a lesion at the temporal occipital junction or in the parieto-temporal area and stuff like that. There is an arbitrary delineation. You can find this notch. I don't actually find this super useful because I think there are a lot of notches on the brain. But it's the temporal occipital notch, and you can draw a line. You can extend the parietal occipital sulcus down to that, and that's sort of an arbitrary delineation between occipitotemporal. And then this is the Sylvian fissure. This is called the posterior ascending ramus of the Sylvian fissure. And if you draw, a perpendicular line from that to the parietal occipital sulcus, that's sort of the arbitrary delineation from parieto-temporal lobes. Okay, and then this is just showing the same thing, on a midline slice. So here we're looking at it. I'm going to have obviously imaging anatomical correlates for these graphics that I'm showing. Here's posterior ascending ramus of the Sylvian fissure. Sylvian fissure is pretty easy to find on any brain. Here's the superior temporal sulcus, which is the next sulcus back. And here's the parietal occipital sulcus coming down. So here's that notch. And so you can follow this down and sort of say, okay, this is temporal, this is occipital. And when you draw that line, you're going to say, this is parietal, this is temporal. And that's kind of what that looks like. Okay. So that can be useful if you want to be more nuanced. I don't dictate that into reports, but I keep it in my head, when I'm talking about where things are. So let's get to the lateral surface. This is a little bit busy, but don't worry, we're going to go through it with some color overlays. So here's obviously the lateral surface of the brain, gross. What do you see in the frontal lobe on the lateral surface of the brain? Well, you see the superior frontal gyrus, you see the middle frontal gyrus, which can be subdivided into the superior middle frontal superior middle frontal lobule and inferior middle frontal lobule, and then you have the inferior frontal gyrus, also called the angular gyrus. And then behind those, you have the precentral gyrus, which is particularly important because it's the motor strip. You can also see a little bit of the orbitofrontal surface here. And those are subdivided by the aptly named, superior frontal sulcus. That's easy to remember. The inferior frontal sulcus, and then the precentral sulcus. So superior frontal gyrus, middle frontal gyrus, inferior frontal or triangular gyrus if you prefer, and then precentral gyrus. And then within the inferior frontal gyrus, you have the anterior horizontal ramus and the anterior ascending ramus of the Sylvian fissure, and that further subdivides the inferior frontal gyrus into pars orbitalis, aptly named because it's over the orbits, pars triangularis because it's sort of triangular in shape, and then the pars opercularis because it's the frontal operculum. So again, all that sort of makes sense, and that's where Broca's area is, for Brodmann areas. So again, talking about form and function, infarcts that result in Broca's aphasia, broken aphasia occur in that area. So temporal lobe is also very easy to understand on the lateral surface. You have a superior temporal gyrus, a middle temporal gyrus, and an inferior temporal gyrus subdivided by superior temporal and inferior temporal sulci. Very straightforward. The parietal lobe gets a little bit more complicated, but it's not too bad. You got the postcentral gyrus right on the other side of the central sulcus, and then you have the superior parietal lobule and then the inferior parietal lobule, which is subdivided into the supramarginal gyrus and the angular gyrus. Those are actually fairly easy to, let's go over the sulci. You have the postcentral sulcus, you have the intraparietal sulcus, which you don't see here because it runs sort of front to back. And then these two are easy to find. The posterior ascending ramus of the Sylvian fissure is just the, superior continuation of the Sylvian fissure. And then same thing, superior temporal sulcus is just the posterior ascending continuation of the superior temporal sulcus. And these two gyri are draped over those sulci. So this is sort of rote memorization, but I think the mnemonic that I have serves to, it's never given me any trouble. Supramarginal is the anterior and higher one. So the one that's over the posterior ascending ramus of the Sylvian fissure, what's called 6 here, is the supramarginal gyrus, and then the other one is the angular gyrus, which is over the superior temporal sulcus. Back here, that's what's 7. And those make up the inferior parietal lobule. So when you're looking at the lateral brain, you're looking at inferior parietal lobule. Superior parietal lobule, you see kind of more on an axial cut or even a coronal when you're looking at the top. Okay. And that's, of course, where Wernicke's is, one of the other famous aphasias, the fluent aphasia, Wernicke's aphasia. You can see a little bit of the occipital lobe here. I don't go over it too much. Remember the occipital lobe, the brain sort of curves around there. So when you're looking at a strictly lateral surface, you don't see much occipital. I'm not going to get into it too much. That's really better understood on coronal. And we're gonna look at the brain on sagittals, coronals, axials, and then midline. So we'll kind of skip over that. So let's just go through that again real quick. Excuse me. There we go. A little something stuck in my throat there. Okay, so inferior frontal gyrus, very easy to find. Here's the inferior frontal sulcus, just the lowest sulcus on that lateral. When you're looking at the brain laterally, and then the Sylvian fissure, again, very easy to find. I kind of tell people, not exactly tongue in cheek, if you can't find the Sylvian fissure, probably radiology is not for you. Consider something else, maybe not imaging based. But here's the Sylvian fissure. You have the horizontal ascending ramus and the anterior ascending ramus, anterior horizontal ascending ramus and superior ascending ramus, pars orbitalis, pars triangularis, pars opercularis. Now, the other thing that this lecture does is it gives you, it tells you not only conserved landmarks, but step-by-step ways to work your way through finding out where you are. So this is where I'm going to start talking about that. So this is a starting point. Like every brain, you should be able to find this no matter what. This is conserved anatomy. Okay, everybody has this. Well, I shouldn't say everybody, but the vast majority of normal brains have this, and it's pretty easy to find even with distortions by tumor and surgery and stuff like that. So the inferior frontal sulcus moves back and it bisects a sulcus that's running, up and down and vertically. And that sulcus is the precentral sulcus. Okay. Well, if you go back from the precentral sulcus, you reach the central sulcus. So easy, right? And if you go back one more, you find the postcentral sulcus. Well, now on the lateral surface, you can definitively tell where the precentral and postcentral gyri are. And that's useful because that's the motor strip and the somatosensory strip. And that has bearing on a lot of things, surgical planning, where lesions are, if lesions explain symptoms, etc. Like, I think, at the bare minimum, when you're reading neuro studies, you really need to be able to definitively tell people what is pre and post central. And if you actually read neuro, you'll realize that although I'm being flippant about that, it's sometimes not easy to tell. Sometimes it can be difficult. This is called the subcentral gyrus. It's not like a real gyrus. It's just something that people, have given a name to. This is actually not conserved anatomy. It's the case in the vast majority of brains, but sometimes the central sulcus will extend all the way down to the sylvian fissure. But generally, this is the configuration you have. And then as you continue to go back, as we talked about, you're getting into parietal. Again, this is the sylvian fissure, continues as the superior or the posterior ascending ramus of the sylvian fissure, posterior ascending ramus of the superior temporal sulcus. And as you'll recall, this is the inferior parietal lobule comprised of the supramarginal gyrus and the angular gyrus, which is Wernicke's area. This little guy is the transverse gyrus of Heschel. It's involved in auditory processing. Okay, so just to recap main points graphically. So I guess I have to talk about it. I didn't do an overlay here, so we'll be quick. Superior frontal gyrus, middle frontal gyrus, inferior frontal gyrus, superior frontal sulcus, inferior frontal sulcus, precentral sulcus. Note this is a dashed line here. That's because this is also not always conserved. Sometimes the sulcus goes up, sometimes it doesn't. But the one that's bifurcated by the inferior frontal sulcus is the precentral sulcus. Then you go back, you've got central sulcus, you go back, you've got postcentral sulcus, and then you can define the gyri related to those sulci. And then again, a superior marginal gyrus and angular gyrus around sylvian fissure and posterior ascending ramus in the superior temporal sulcus. Okay. Whew. Like I said, I kind of skipped the occipital lobe because I don't find it to be that useful on sagittal. So we'll kind of get over that. I'm just going to touch basely on the insula and operculum. It's important to kind of know what they are and know where they are. If you spread the operculum like this, you reach another, it's actually cortex in here. You spread that open, you expect white matter, but no, you find the insular cortex. So the operculum, which means roof, there's a small frontal operculum. We talked about that, the pars opercularis, and most of the superior aspect of the operculum is parietal operculum. That's the roof of the sylvian fissure, right? This is the sylvian fissure here. So this is, unfortunately, these color codings don't match up, but the superior part's green. And then the temporal operculum is the floor of the sylvian fissure, and the insular cortex is the median or the medial boundary. So you can kind of get into the weeds with the insula even, although I don't think that this is necessary. I never talk about this in dictation, but just so you know, there's a larger anterior insular lobule, which has the anterior, middle, and posterior short gyri. And then you have a posterior insular lobule, which has anterior and posterior long angular gyri. And if you look, you can actually see these things on MR if you have adequate resolution. I think, again, that's not super important, so I'm not going to spend a lot of time on it. Okay, medial surface of the brain. This is another one where you can really get some useful information and useful landmarks. I use this a lot. It's best understood radially from the inside out. So starting with the corpus callosum. And again, this is one of those things I say, if you can't find the corpus callosum, you know, maybe go into banking or forestry or something other than medicine, and certainly not radiology. So corpus callosum is the, you know, the midline commissure here, and you have a little rostrum anteriorly, then you've got the genu, the body, and the splenium. You also have periterminal gyrus and inducium griseum, but these, again, kind of get into the weeds. I'm going to gloss over that. So right adjacent to the corpus callosum, you have the aptly named pericallosal sulcus. That's the sulcus that's sitting right here, adjacent to the corpus callosum. As you go out radially, you reach the cingulate gyrus, and you have the subcallosal area and the isthmus, but basically you have the cingulate gyrus. This is another gyrus where a lot of people, I think, misplace things. They'll describe things as being in the frontal lobe on axials, when you could kind of more aptly say that it's in the cingulate if you're paying attention to sort of where you are on a sagittal, for example. Then as you continue out, so this is pericallosal sulcus, this is the cingulate sulcus. So you'll note that they're named for the thing that is under them, or, you know, inferior to them. And then this is what you really need to pay attention to. The cingulate sulcus exits the surface of the brain as the pars marginalis of the cingulate sulcus, sometimes referred to as the pars marginalis, P-A-R-T-E-S. I think I go back and forth within this lecture, but the pars marginalis of the cingulate sulcus. And this is very important because it will help you define the central sulcus on a midline slice. And the central sulcus is the next anterior sulcus from the pars marginalis. This is also a fun sort of, you can call it what it is, trolling technique that I've used in lectures with faculty from other departments, faculty and residents. I like to put up a sagittal midline sequence when we're going over cases and invite people to tell me where the central sulcus is. And almost invariably, people will pick this sulcus. On the midline, they'll say, okay, the biggest sulcus back here is the central sulcus. It's not the case. The central sulcus actually, and we'll look at this when we get to the axials, it doesn't really come all the way to the midline. On the midline, it's a small sort of nondescript looking sulcus. The big sulcus here, and again, it's also the one that is in continuity with the pars marginalis of the cingulate sulcus is the cingulate sulcus. I have two side by side here because this brain wasn't cooperating with me. You can tell it's not even the same patient because this is a post and this is a pre, but I didn't have a picture of it nicely like on FOSS in one, but you know, you can follow it all the way along and then it goes up. So pars marginalis, the next anterior sulcus is the central sulcus. Another thing to notice here is that the motor strip is thicker than the somatosensory strip. So that can kind of key you in. And actually, I forgot to say that, but if you go back and look at it here, you see the same thing. The motor strip is thicker than the sensory strip. And that just makes sense, I guess, in terms of like motor connections. So that's useful. And here's the pars marginalis of the cingulate sulcus coming up. That's what you're seeing on the sagittal. And then the central sulcus doesn't come all the way. It's not a midline sulcus. So it just sort of protrudes over there. And then here's the paracentral lobule. This is sort of the, the superior most counterpart to the subcentral gyrus. And that's why I was saying some people consider, the pararlandic cortex to be this, this separate lobe or fifth lobe where you can, trace your finger from precentral, under subcentral, back up somatosensory, and then over the paracentral lobule and kind of make this circle. But that's just something some people say. It's not, I think, canon or anything like that in neuroanatomy. Okay, and this was just a reminder, again, of the same thing. If you continue laterally, remember here's inferior frontal, precentral, here's central, and then you have this thicker post-central, I'm sorry, this thicker precentral and skinnier post-central or somatosensory gyrus subcentral lobule here, and paracentral on top right here. Okay. So easy, right? I mean, when you go through this, it's actually, it makes a lot of sense. Ancient anatomists, like they didn't do too much crazy. It kind of was laid out logically. Okay, so this is another sign that I find to be super useful in the sense that it's conserved and it's very easy to find. They call it the lazy Y sign. So it looks like a Y, right, in yellow, and it's lazy because it's on its side. So yeah, the lazy Y sign. And the lazy Y sign is where the parietal occipital sulcus, which again is an important sulcus because it separates parietal lobe from occipital lobe from the calcarine sulcus. This is also one of my pet peeves when people put things in the parietal occipital region, you know, because they don't know how to separate them, because that's a hard anatomic boundary. You know, my residents will say, oh, there's a metastasis in the parietal occipital region. I said, well, is it parietal or is it occipital? You know, it's not one or the other. Now, sometimes it is, you know, in infiltrative gliomas and even infarcts and stuff, because of there's, you know, a little bit of a watershed there. But, you know, if you can be more precise, then you should be more precise. You shouldn't lack precision because of a lack of anatomical knowledge. And in some cases, you know, I tell people, I say, look, when you think about stroke, for example, you're saying something very different if you're saying you have infarcts in the parietal occipital lobes versus just parietal or occipital, because the vascular territories are different. You know, like, are you saying that something involved both the anterior and posterior circulation, or are you saying it's, you know, just like at the watershed? You know, what are you saying? So it's an area where it does not behoove us to be lazy in how we describe things. So I think that the lazy Y sign and kind of understanding that's important. You know, they come together to form the anterior aspect of the calcarine sulcus. That's this here. Okay, so it defines the precuneus, this guy, which is part of the superior parietal lobule. And remember what I said earlier, we're midline here. We're kind of superior midline brain. So that's where the superior parietal lobule is. Inferior parietal lobule, I'll remind you, is supramarginal and angular gyri. You know, you see them more kind of on the inferolateral, or I should just say lateral aspect of the parietal lobe. From the cuneus, which is part of the occipital lobe, and the lingual gyrus here, you can also call this the medial occipitotemporal gyrus or lingual gyrus. I think because it looks like a tongue, not because it has anything to do with the tongue. It's actually visual cortex. Okay, and here it is on, as promised, on you know, just sagittal T1 for the actual imaging. So again, you know, I had to lay it out in two, you know, in two side by side slices here, but anterior calcarine sulcus, and then you have this lazy Y here. This is parietal occipital, and this is calcarine, and you've got, I think I probably did the overlays. Yeah, precuneus, cuneus, medial occipital temporal gyrus or lingual gyrus. This is like, this is described in the paper that I read, so I kind of put it in here when I was making this presentation, but I don't find that I use it much. But it separates parietal from it looks like it's supposed to look like an H. It does look like an H from cingulate, but I don't know. I don't find that to be a derivation that I draw too frequently. And again, always remember, you know, whenever you're confused, don't stick to one thing. You know, I tell people, I tell my trainees, you really need to be able to correlate and move between axial, sagittal, coronal, axial, et cetera. And you should understand what you're seeing in multiple planes. So the lazy Y sign, this same type of anatomy can be understood pretty easily in the coronal plane. And I find, you know, especially when you're talking about occipitoparietal, you know, the coronal is useful. So here's the calcarine sulcus that we talked about. It is simply the inferior most horizontal sulcus above the tentorium. So it's super easy to find. Again, you can't find the tentorium, become a fireman, a policeman, right? Go up, there's the calcarine sulcus, okay? The next one up is the parieto-occipital sulcus. So if you've got a Met here and you're telling me it's occipital, I'm going to be disappointed. I'm going to say it's not occipital. It's very clearly parietal, because here is the parieto-occipital sulcus. Tentorium, calcarine, parieto-occipital, meaning parietal occipital. So easy. You just have to kind of pay attention to these things. This kind of stuff, it indents the occipital horn of the lateral ventricle. That's true, but I find it less useful because, the brain can get confusing and you're like, is that really indenting it? Is it not? I don't know. But technically that's described. Okay. And then when you go laterally, you have the intraparietal intra-occipital sulcus. This one's traveling, craniocaudal or vertically, and as it says, it goes through both parietal and occipital lobes. So, again, this is occipital, this is parietal over here. All righty. This is medial occipitotemporal or lingual gyrus. Here's the cuneus, part of the occipital lobe, precuneus, superior parietal lobule, which we talked about. And then when you go laterally, you're in the inferior parietal lobule. This is the angular gyrus. The supramarginal gyrus is more anterior. If you remember, the angular gyrus is more posterior. That's why we call the supramarginal gyrus supramarginal. Supra means above, so it's more anterior here. This slice, I'm just going to go through. This is an interactive lecture in some cases, and I have trainees kind of name these things, which I'm not going to go through in the virtual format. But I also think that you should be well versed with the major structures in a midline slice of the brain. I tell, I think probably different places have different protocols for MRI brain, but I'm pretty sure everybody probably includes a sagittal T1. And I say it's important not only because it's the T1, but the midline sagittal slice is a super important slice to look at. This is true of CT or anything else, because it's the best place to look at the suprasellar regions, really kind of, in my opinion, the best place to look at craniocervical junction, best place to look at pineal region, or at least the places where pathology there is, stands out the most or makes the most sense. You need to look at it. You need to kind of know what you're looking at. So just really quick, you've got the pons, you have the infundibulum of the pituitary gland, you've got the optic chiasm here, you've got lamina terminalis of the third ventricle itself, anterior commissure, interthalamic adhesion. Here's a fun thing that was taught to me when I was a faculty by a neurology resident. I kind of didn't believe her. And then I fact checked her and she turned out to be correct. So, you can always learn things even about stuff you think you know a lot about. She told me that the interthalamic adhesion is not a conserved structure. And I said, pretty sure it is. Well, it turns out it's not. It varies in size. And if you really pay attention, not everybody has a connection between their thalami. Again, it's one of those things that most people have, but if you look at a lot of brains, you'll see that the interthalamic adhesion is not present in everybody. So just interesting trivia there. You got the fornix, the tectal or quadrigeminal plate with the inferior and superior colliculi, mammillary bodies. Mammillary bodies kind of important to know about for various pathologies. Midbrain, tuber cinereum, the medulla, and then the obex, where the fourth ventricle starts to drain into the central canal of the spinal cord, made by the nucleus gracilis here, this little hump. Okay, so we're deep into the lecture now, and we're going to get to the superior surface and the axial surface, which is how people sort of classically, I think about cross-sectional imaging in the axial plane. As we know, as radiologists, it's only a part and sometimes a smaller part of the story. So this has been described as, you can understand it as a clock face. I don't know that I think that's that useful, but we'll go with it. So interhemispheric fissure, this is if you can't find the interhemispheric fissure, become a ballet dancer, something else. It runs 6 to 12 o'clock. when you go lateral to it, you're getting into the superior frontal sulcus. Okay, so super easy to find that. And then you can start to do, okay, here's superior frontal gyrus, here's middle frontal gyrus. If you want to get into the weeds, it's the superior lobule of the middle frontal gyrus, but I don't think that's super important. Some of this stuff is just here to remind you, pars marginalis of the central sulcus. This is paracentral sulcus. I don't find that to be useful. Again, because this is a flattening of all the sulci, just for the record, these don't line up side to side. You can't see all these at once on imaging. You have to scroll through them. So just to be clear about that, there's more labeled here than you can see here. So that's midline. Off midline, the suprafrontal sulcus, and this is another one of the things I find very useful. Okay, the superior frontal sulcus will traverse anterior posterior, and it will intersect, or sometimes this gyrus goes between them, but it intersects or comes very close to intersecting this sulcus, which is the precentral sulcus. When you move one back, you're at the central sulcus. So when you're looking at axials, this is a useful way to separate, to find the central sulcus, and then of course to find precentral gyrus and postcentral gyrus. Because again, central sulcus, you go back, postcentral sulcus, and here's the paracentral lobule, as we talked about. Okay. When we go back from that, the postcentral sulcus, which is here, continues posteriorly and inferiorly to become the ascending portion of the IPS-IOS, which we saw earlier on the coronal, right? The intraparietal sulcus, intraoccipital sulcus. And as we saw again on that coronal, that's separating superior parietal lobule, which is superomedial, from inferior parietal lobule, inferolateral, which can be, supramarginal and angular gyri. This is just a reminder of what you're looking at on the lateral that we already talked about. Okay, and this is where it gets kind of confusing, but here it is again. So superior frontal sulcus, superior frontal sulcus, precentral sulcus, central sulcus, postcentral sulcus, continuing inferiorly as the IPS-IOS, the intraparietal intraoccipital sulcus here. And then this is, remember also, just kind of use your head, right? It runs vertically. So as you get down, it has this very characteristic curvilinear appearance. And when you're lower down like this, it looks like it's running anterior to posterior. So it's easy to find. And then you can do things like say, okay, here's parietal lobe. This is the parietal occipital sulcus. It's been described as a fishtail sulcus. Again, I don't find that useful because the sulci all kind of look like fishtails to me. But if that helps you, okay. Separating median parietal lobe from, this is superior occipital gyrus, and you have middle occipital gyrus. Now, these are things that you can look at. I will tell you, I do not. And the reason for that is because to me, this anatomy is so much easier to understand on the coronal or, the midline sagittal plane, as I showed. So this is just, I'm showing it here to show that it correlates, and maybe this makes more sense for you, but I firmly believe in the work smarter, not harder, mindset. This is a confusing way to understand this particular part of the brain to me. So when I'm trying to decide where things are, I'll put what do you call it? Like a cross-reference line, on my imaging, and then I'll go to the coronal and be like, okay, where am I? Oh, okay, I'm occipital. All right, this is occipital. I won't try and do it here just because it's harder for me. So this is just a recap. So sulci, they're labeled here. If you go back through, because this is being recorded and watch this, A, superior frontal sulcus, C, and they go kind of back and forth because again, they're not shown on both. C is the precentral sulcus. Remember, these are going to connect or bifurcate. Keep going back, you get to the central sulcus. It's D here. E, postcentral sulcus, just makes sense. And then FG is the intraparietal intraoccipital sulcus with this sort of curvilinear appearance. As you get posterior, remember, it's going to be running sort of straight forward, front to back. Okay. And then on the gyri, sort of in the midline and a little bit, notice we're sort of deep into the brain here. You've got cingulate gyrus. 1 is superior frontal gyrus, easy. 2, middle frontal gyrus. 4, precentral gyrus, which is motor. Again, notice that it's thicker than the postcentral gyrus. Another just kind of useful thing that you can use. And then 6 is the supramarginal gyrus that's here. And then 7, angular gyrus back here, part of the inferior parietal lobule. I know I do a lot of repetition, but repetition is one of the things that helps with retention. So, I kind of repeat things a lot because I also know that anatomy is kind of dry. You probably lost like 25 to 50% of you at this point in the lecture. Okay, signs to identify precentral and postcentral sulci. These are all things, again, that I've already said, but I'm just going to repeat them here because I think that at the very least, after this lecture, you should be able to confidently identify where you are in the perirolandic or in the rolandic cortex. So again, we just did this one on axial. You follow the superior frontal sulcus back until it intersects the precentral sulcus. The next posterior sulcus is the central sulcus. If you know where the central sulcus is, you know where the precentral and postcentral gyri are. Another characteristic is the hand motor knob. It looks like this sort of prominent lobule, I guess, in the precentral gyrus, and that's just because of the the amount of cortical space that's given to the hand. Your hand is amazing. I was listening to a hand surgeon on NPR. He was somebody who does like microscopic like nerve repairs and stuff like that. Somebody with like an unbelievable amount of training. He had done a residency in plastic surgery and vascular surgery, like both, to reconstruct people's hands. And he was saying that that your hand can play the piano and it can also smash bricks, and I think that I was just like, yeah, it's true. You don't think about it. You kind of take your hands for granted, but they're so versatile. They're really amazing. Okay, so sagittal, on the midline sagittal, you can follow the cingulate sulcus, which again is easy to find, back to the pars marginalis of the cingulate sulcus, where it exits the surface of the brain. The next anterior-most sulcus is the central sulcus. And again, motor, precentral, thicker than sensory, postcentral. And then sagittal on a non-midline, on the sagittal, lateral sagittal of the brain, the inferior frontal sulcus, which is again very easy to find, will intersect the precentral sulcus as well, and then the next posterior sulcus is the central sulcus. So let's go to the inferior surface, sometimes called the orbitofrontal sulcus. I'm having a very hard time with that. The orbitofrontal surface. Try and say that 3 times fast. Orbitofrontal surface, orbitofrontal surface, orbitofrontal surface. That's a tough one. That's a tricky one. Okay. Anyways, so you got the olfactory sulcus, pretty easy. It's got the olfactory nerve and bulb in it, cranial nerve 1, which you can actually see on adequate coronal MRIs. So that's easy to find, and it defines the gyrus rectus, which means the straight gyrus, which is also easy. It's just this straight midline gyrus here from the orbital gyri. The orbital gyri are these 4 sort of H-shaped described gyri. Now you can see them here on this graphic. On a brain, you can't, because you can't see them all at once because the brain slopes like this. But they're easy to kind of scroll through, and they're really easily named. Just medial, lateral, anterior, and posterior orbital gyri. Again, not something that I use a lot in dictations, but if you really want to be specific about where you're putting something, that's kind of what they're called, and they surround these orbital sulci. The posterior medial orbital lobule, the PMOL, is the medial orbital gyrus and the posterior orbital gyrus. It forms the anterolateral wall of the sylvian fissure. So this is a slice right above this. This is superior, and you see the PMOL kind of goes right over crosses over the sylvian fissure and merges with the apex of the insula. So this is a pathway for tumor spread. for infiltrative gliomas and stuff like that. So it can be useful to kind of understand that anatomy. If I'm being really honest, I don't talk about it much. This is, I think, my bane. I would say this is the most complicated part of the brain for me to understand. I don't like the inferior surface of the brain, but I'll go through it. So infralateral surface, you've got the inferior temporal gyrus anteriorly. We talked about that on the lateral surface, and the inferior occipital gyrus posteriorly. Remember, there's an arbitrary division there. You can kind of try and find the occipitotemporal notch, but there's not like a sulcus separating these, which is why these things have names like the occipitotemporal sulcus. It's going through both, and the gyri are the same. So you have lateral occipitotemporal gyrus, the LOTG. Then you've got anteriorly the rhinal sulcus, the collateral sulcus is this posterior continuation. Then you've got the medial occipitotemporal, remember, sometimes called the lingual gyrus, and then the anterior calcarine sulcus. And then you have the interrhinal cortex, part of the limbic lobe on the inferior surface. Okay. Hippocampal formation really could be a lecture in itself, so I cover it pretty superficially. There are 5 gyri of the anterior temporal lobe. This is anterior temporal because more posteriorly, you also have the medial occipitotemporal gyrus, which doesn't extend as far anteriorly as where you're generally looking at the hippocampus for like mesial temporal sclerosis and things like that. This is the level of the temporal stem. So that's another useful anatomical term. The stem is sort of this white matter that connects the white matter tracts and the centrum semiovale corona radiata to the temporal white matter here. It kind of looks like a mushroom is what I think. It's a stem. It goes in here. So this is at the level of the temporal stem right here. So you've got the hippocampus rolled into the temporal lobe to make the medial wall of the temporal horn. That's this little purple asterisk here. This is hippocampus. And you've got 5 temporal gyri. 3 of them we already know: superior temporal gyrus, middle temporal gyrus, and inferior temporal gyrus. Boom, boom, boom. Pretty easy. You've got the lateral occipitotemporal gyrus, which we just saw on the inferior surface. It has a bifid white matter arrangement, so it looks like sometimes confusing spinous processes in the cervical spine. Sometimes they do that bifid thing instead of being straight, and trainees who don't have apt experience call them fractured. And then the perihippocampal gyrus, which is the medial most, the inferior medial border of the temporal lobe. And then you got sulci to match, right? From lateral to medial, superior temporal sulcus and inferior temporal sulcus, those are pretty easy. We learned those on the lateral surface. And then, on the inferior surface, we talked about the occipitotemporal sulcus, and then the collateral sulcus, which is posterior. Anteriorly, it's the rhinal sulcus, and then the perihippocampal fissure. Whew. Okay, that's the end of the lecture. This is just a recap, and it kind of goes over in graphic form the walkthroughs that I want to give you. So I'll just go through them again real quick so you have my voice if you want to go back and look over this. Starting with the lateral surface, remember, you can find very easy Sylvian fissure, anterior and ascending rami of the Sylvian fissure, okay? So if you can find that, you should be able to find that, then you can find the inferior frontal gyrus, okay? Go above the inferior frontal gyrus, you've got inferior frontal sulcus, easy, okay? That's going to bisect this sulcus, which is the precentral sulcus, and it goes all the way up here. Remember, there's some variations here about what this thing does in terms of its scope. Sometimes it connects here, sometimes it doesn't, but it's pretty easy to find. You go above that, you're in middle frontal gyrus, okay? Middle frontal gyrus, the next posterior one back is precentral gyrus. If you go back again, you're at precentral sulcus, right? Or you can also say precentral sulcus, central sulcus. This is, I think, the transverse gyrus. Oh, no, I'm sorry. This is the subcentral lobule that they're showing you here. You go back from central sulcus, you're in postcentral gyrus. Easy, right? Here's postcentral sulcus. Here's IPS, IOS, which, again, is maybe easier to understand on imaging on axials, but they can show it easily in this graphic here because they can flatten everything And that's gonna define superior parietal lobule from inferior parietal lobule. Remember, inferior parietal lobule has supramarginal gyrus anteriorly over the posterior ascending ramus of the Sylvian fissure. And then here's superior temporal sulcus, and over the posterior ascending ramus of that, the superior temporal sulcus, you've got angular gyrus. Remember, supramarginal and angular gyri make up the inferior parietal lobule. And then here, this is just showing you the superior parietal lobule. So easy, you know, step by step, very simple. And then here's the radial, you know, midline, again, corpus callosum, pericallosal sulcus, cingulate gyrus, cingulate sulcus with pars marginalis of the cingulate sulcus, which is how you can define the precentral sulcus. I'm sorry, the central sulcus. And again, not a particularly dignified sulcus on the medial surface, just this little guy here. I didn't talk much about this, but they call this the paracentral sulcus and the paracentral lobule, whatever. The little H we talked about. But more importantly, I think the lazy Y sign with parieto-occipital and calcarine sulci separating parietal from occipital, specifically precuneus, inferior, superior parietal lobule, and then cuneus, which is occipital lobe, lingual gyrus, or medial occipitotemporal gyrus, if you're not into the whole brevity thing. We didn't go through a lot of this, which is fine. I think this stuff is kind of in the weeds. And then finally, the axial surface, again, interhemispheric fissure, superior frontal gyrus, superior frontal sulcus, middle frontal gyrus, superior frontal sulcus bifurcates, precentral sulcus. Then when you go back, you've got precentral, central, postcentral. Postcentral is going to continue as the intraparietal, intraoccipital. And if you know the sulci, then, you know, the gyri fill in pretty easily. And like I said, this stuff down here is confusing. And I don't understand why you would even describe it, because you can't do this in imaging. You can't flatten it out like this. So showing it like this, I think, is not super useful. But they've got the pars marginalis and the central sulcus. They describe this sometimes as a Dali mustache. Again, I put that in like the fishtail sulcus. I'm like, they all look like Dali mustaches and fishtail sulci. So in my opinion, that's not useful. But this relationship of the midline pars marginalis and then the central sulcus coming in is kind of useful. Okay, we're right at 8 o'clock. That's where I hit my my final slide, and give my appreciation, if you're still with me, for hanging on through that lecture. And that's it. Thank you very much.
Yeah, thank you. That was great. I hope this is Sheila from AKU, Aga Khan University. And I'm really hoping the residents realize I'm not just being hard on them for wanting to see something more definitive than parieto-occipital. And I also hope I'll be seeing more of gyrus rectus and orbital gyrus instead of antero-inferior frontal, which I sometimes use for trauma, but not for actual lesions. So thank you so much for that. I just took the chance to say thanks, but I wonder if any residents from any of the institutions participating have any questions. I think that was great. I hope you don't mind us recording it, because we want to go over it again and again, if that's fine with you.
Yes, that's fine. I'm not
all right.
Proprietary. It's okay.
Okay. Thank you for that. I don't know if there are any questions, if Dr. Abuya or Dr. Onyambu would like to make some comments, but on behalf of AKU, thank you. Thank you for taking the time.
It was really my pleasure.
Thank you. Thank you. This is Dr. Nyamu from University of Nairobi. We really appreciate that. It's an excellent presentation. I think we will access it so that the residents can go through it again and again, so that they realize that the emphasis on anatomy is key, and you've really laid it out quite well for us. I thank you again.
And listen to your faculty. You know, it starts with neuro, but it's super important in head and neck too. You know, learn your neck anatomy.
Yeah, the space is the place, right? With the head and neck, yeah. I see one of our residents is asking to review the salsa of the hippocampal formation, but Subira, we are recording this, so I think we'll be able to look at it if that's okay with you. Because we are finishing our day, we're ending our day, but you're starting yours, Dr. Bulia.
And I have
Thank
4-year-olds,
you.
2-year-olds. So.
Thank you, John Heyman. My name is Joseph Abuja from Moi University. We have 3 universities who are training residencies. One is, as you have heard, Aga Khan University, Nairobi, University of Nairobi, as well as Moi University. I hope that this timing of 7 a.m. Central American time is okay with you. If it's okay, we'll continue for the time being having these lectures and case reviews at this particular time, which is 7 a.m. at your place and 4 p.m. at our place for both Thursdays and Fridays. We'll go later and look at the various virtual reporting or the various case studies. Of course, you'll have to give us probably that head and neck lectures as we later go to other regions of radiology like musculoskeletal imaging or even breast imaging, but we'll see on how it works. So if this timing works for you, we are happy. But if it does not work for you, you'll tell us. Then the other thing is that I'm hoping that our residents have really enjoyed the class. And I wish that later on we'll be having various teachings or case reviews, they may be by Jay Starkey, or I was impressed, he talked about Nickerson, whom I think I must have met in Kenya some time back. Also, we'll hear from Bruno and the others. Thank you very much for our first meeting for today. Thank you, all of you. Bye.
All right, I just needed to ask, how often were you hoping to have sessions, or is it, say, quarterly or?
Yeah, so, oh yeah, go ahead.
Oh yeah, I'm not sure who that question was directed to. Please answer it. I'm willing to give more sessions, but I kind of signed up for I'm not sure what the expectation is, but I was going to say that I probably have colleagues that would, also be interested in participating. So we could potentially provide more people. I think this time works for us, generally speaking.
Okay.
Yeah, I
that's
think
great.
So basically, I think the intent of the original intent, at least of this particular program, was to have like a session, but I think it would be great to be able to establish something and like more continuous, and I'm happy to sort of facilitate that through the international committee. So we could, Dr. Hyman, if you're okay with it, we could continue to sort of figure out a time that works. And maybe we could also have like a more clinical session where people submit interesting cases, and maybe, like, for example, next time, maybe there are a bunch of cases where there are tumors that are, or injuries or something that are in particular parts of the brain, and we could see if we could tease out which particular area is actually affected, especially if it was difficult because of distorted anatomy or something like that. And then your expertise on being able to identify those sulci, I bet, come in even more and sort of reinforce all the concepts we learned. But I'll let Bruno sort of chime in as well, since he's the director of the international committee.
No, this was great. I want to say, John, thank you for your lecture. And I would say that the goal of the international committee is really to foster long-term relationships. And there's definitely a mechanism for us to do this more often. This specific one, this virtual reading room, was intent, as Jay said, for one time, but we can definitely, and Jay can help facilitate that because he already has communicated with you guys so much that we can do more of a long-term and perhaps set up a recurrent lecture. We have an upcoming session for our committee after RSNA that we can discuss it further. But in the meantime, Jay, we can, there's definitely something that the committee would like to support and I would like to support. So let's work on that. what I would ask, just if you are comfortable turning on your camera, I would love to take a picture, a screenshot of who is here. If you're not, that's okay as well. Your name will show up on the picture, but I'll give everybody like 5 seconds if you want to turn your camera on, and then I'll just do a screenshot. This is amazing. We had 76 attendees, and really shows how this collaboration is impactful. So let me take a picture right now here. I'm gonna do my, I'll give them. Okay, let's do this here. It's so good to see so many faces. Let me see here. One. Okay, I'll do another one.
I have at least one resident from Aga Khan, actually.
Good, thank you. Go ahead.
Oh, nice. I see Greg Obala is on, it looks like, too. He got up early.
Yeah, this is good. And I think that the example of, I'll just give a little brief what the International Committee really is for the ASNR. We started with in-person collaborations through the Ann Osborne program, where we send 10 visiting professors throughout the world every year. And we also have twice a year an international imaging series that we've done in many countries. When COVID started, we had to put all the sessions in a hiatus, and then we switched to this virtual environment where and the goal for this virtual environment was to create a more interactive, specific for the country. And so we've done a few countries, and now that COVID is getting better, we're starting to resume the in-person visits. We actually just are going through the selection for 2023 for the 10 visiting professors. But we'll continue to do the virtual. And also to add, if Kenya is interested in being part of the Ann Osborne program and having actually a professor come on site, there is I'll send through the email a link that's on the website that you can apply to be a host country. So there's definitely various ways to collaborate with the ASNR.
Thank you for that. Yes, we had Dr. Nickerson come round a few years back. So, well, we'll see. We'll be communicating between all the three centers and see what we can come up with. But I think it's worthwhile, definitely. So I guess we'll be communicating between each other when you're ready. I know with Christmas coming up, and I know for you also Thanksgiving, it's going to be a busy season, but maybe thereafter. Yeah.
Perfect.
And maybe just to mention something, Bruno, I think it was maybe 10 years ago when I was still a resident that Ann Osborne actually came over. And she did do some lectures with Aga Khan and also University of Nairobi. And they had initiated that visiting professor program, but it never quite took off after that. So I think it's worth reconsidering and restarting it afresh. So thank you for bringing that up.
Excellent. Yeah, that would be great. And we definitely, it's great for the host country. It's also great for the visiting professor, and really has fostered a lot of great collaborations. I think we can see with Greg Obala, that's a great collaboration, and have this opportunity to exchange knowledge. So thanks everyone. And Jay, thank you very much for being the glue of this and helping organize and getting this up and going.
All right. Well, yeah, thank you again, Dr. Hyman, for a very interesting lecture. And I think that the depth and breadth of anatomy in a very small space is what often gets people interested in neuroradiology. And I think we tend to like the minutia and really get into it versus, you know, the body has a lot more space and you could probably get into a lot more minutia there, but people tend not to love it quite as much as maybe we do. So it's really nice to have a really detailed lecture on all of that we can see. And certainly, you know, like when you get into a functional MRI and you see activation in the transverse gyrus of Heschel, for example, it's a really important area to understand where its location is. So,
Okay.
But anyhow, thank you again so much for taking the time to do that great lecture, and we will continue to collaborate.
Yeah, please reach out.
All right,
All right.
thank you.
Thanks,
Bye, everyone.
Okay, thank you. Bye.
Hi.